Good morning, good afternoon, and good evening. Another on-demand series here at Scottish Rite based on your feedback and your comments, so please keep them coming. This is a two-part lecture series on fractures and imaging of fractures. I think you're going to find it really interesting and engaging. We have two speakers for you today. The first one is Gerad Montgomery, who is the leader in our fracture clinic here at Scottish Rite in Frisco. His background is he received his Bachelor in Science in nursing and his master's at Baylor University before doing additional training in pediatric orthopedic, and now he's an expert in fracture management. Not only treats it, but he educates many of you guys in how to take care of pediatric fractures. Part two of our series is Manish John. He is a radiologic technologist here at Scottish Rite. He's been here for 13 years and he manages the campus here in Frisco. He has a passion for teaching and teaches many radiology students on how to take proper imaging and proper techniques, certainly for certain fracture types. The benefit of his lecture is it's actually in the X-ray suite today. So he's going to give his lecture in the imaging suite, show you how he positions certain body parts, investigating certain body types that can help you in your pediatrician's office or in an urgent care center. These lecture series are directly because of your feedback you've given to us. So please keep them coming. Hopefully you'll enjoy it today. We're going to start off with Gerad Montgomery.
Thank you for that introduction, Dr. Ellis. I'd like to thank everybody for joining us today. I really appreciate your time, and I hope that you all get something out of this lecture. Hopefully you can walk away with some pearls that are helpful in your day-to-day practice. We do have a lot to cover, so I'm going to go ahead and get started. I have nothing to disclose. We've listed our objectives here clearly. I'm not going to go through these one by one, but I do think it's important to mention, I truly believe that a step-by-step methodical approach to reviewing x-rays is really important, much like our clinical exams. There's several ways to do this, and probably if you ask 10 people, you may get 7 or 8 different answers. I think one of the mnemonics I use to help me is kind of this ABCS. So adequate and appropriate views, and what I mean by that is if you're shooting a hand for, say, you're going to need 3 views, whereas a wrist is usually 2 views. So depending upon what you're evaluating, it may vary on the amount of views that's kind of your standard protocol for an order. It's extremely important that you have all of those views that are necessary. And then making sure that those views are adequate. Just because you have all 3 views or both views doesn't mean they're good views. And the views really need to be adequate for you to be able to evaluate them and make sure you're not missing anything. Our bony alignment, just kind of overall bony alignment, important to look at when you first glance at that x-ray. The cortices, I like to trace the cortices of these bones kind of one by one, going around them looking for subtle step-offs or irregularities that may tip you off to a really subtle fracture, especially in pediatric orthopedics. There's a lot that can be missed as some of these injuries can be quite discrete. And then our soft tissues, those are always good to kind of evaluate on your x-rays as well. They can kind of lead you to kind of further hone in your exam and evaluate a certain area that you may need to look at that didn't really look all that suspicious initially on the x-ray. We're going to start with a 10-year-old gymnast who presents to your urgent care at 10:30 p.m. By the way, you close at 11 p.m. With the below injury and clear clinical deformity of the wrist. So you can see on this x-ray here, there's a pretty good deformity there. Her exam, she does have this deformity. She's intact. It's a closed fracture. She's calm, fairly comfortable, and neurovascularly intact. This is our typical gymnast. They're tough. They're just very, very tough kids. So again, it's almost 11 o'clock. You and your staff have been there for a long 12-hour shift. It's been a pretty tough day for you. And this walks in, and now you're kind of wondering, boy, is this something that I need to send out to an emergency room to get a closed reduction done? Is this safe to splint? Not really sure what to do with this. So, like we often do, we phone a colleague. You reach out to your orthopedic colleague to ask for advice. He informs you that he's in an area with really poor reception and service, so he's not receiving the images you're sending him, but he wants you to just describe it over the phone. So I'd like you to pause for a minute and think about how you would describe this fracture. To some of you, it may come pretty easy, especially if you've done a lot of this before. But if not, orthopedics, one of the most challenging things we find when people start with orthopedics is that it's kind of its own language. And so there's some terms that we can really use to kind of help communicate that. And I would encourage you to kind of learn these terms and be able to describe fractures in these terms. So closed versus open. So is this a closed fracture, an open fracture? Pretty basic. Or proximal to distal. So proximal is towards midline. Distal is away from midline. Are displaced versus non-displaced, or is this fracture angulated or not? Apex dorsal versus apex volar, particularly on our upper extremities. So our volar aspect would be your palm side, where the dorsal aspect would be the top of your hand. And then intra-articular, extra-articular. Shortening is their shortening of the fracture pattern. You can focus or learn these other descriptors, but I would tell you these are probably a little less important. The oblique fractures, usually with pediatric long bone fractures, can occur, and those are pretty easy to describe as well. But going back to our case, so if we're going to look at this one, this is not, if this is our forearm here, the proximal end's down here by our elbow, our distal end's down by our wrist. There's a radius and an ulna fracture we can see. So this is a distal third radius and ulna fracture. I would say this is an apex, so the direction the fracture points to is the apex, and that's an apex volarly angulated fracture. You could further quantify that with maybe this is a 40-degree apex volarly angulated distal radius and ulna fracture. If I'm on the other end of that line, that gives me a pretty good idea of what you're looking at and kind of helps me feel comfortable giving you advice as far as what to do next. Let's try that again. So a little bit different. So we're not proximal and we're not necessarily distal. This one I would say is a mid-shaft. You've got angulation both on your AP and your lateral view. So when you're looking at this, you could describe this AP view with apex ulnar angulation if you wanted to. On our lateral view, this is again apex volar, and you can see there's some shortening in this fracture. So this would be a mid-shaft radius and ulna fracture with maybe, we'll call that 40 degrees as well of apex volar angulation, some shortening of both bones. And again, you could also throw in that on the AP, there's some apex ulnar angulation noted as well. Again, gives me a pretty good idea of what's going on. I would further include specifically on these shaft fractures, really important to check that skin and make sure this is not an open fracture, so you can report that it is closed when you're trying to describe this. How about another one? We're going to look at this one, and I think at first glance you look at this and say, well, I have two of the same views. Where's my lateral? And I would tell you, I think this is an attempt to get a lateral. You can see the positioning of the hand is a little bit different, but nonetheless, we don't really have a good lateral view. It makes it a little challenging to describe this and really understand where this fracture alignment sits. So not only is it a little hard to describe, but sometimes when you have a really bad view, it makes it challenging to decide what exactly is needed and kind of plan for, is this going to need an IV for conscious sedation, or is this going to need a little bit of oral pain medication for a well-molded cast? So when we repeat these x-rays and we go ahead and move forward on getting new views, you can see with just a little bit of repositioning, boy, it makes a big difference in what this fracture looks like. So our AP looks pretty anatomic. Our lateral view has a little bit of apex volar angulation, but it's pretty mild, and this is much easier to describe now. Let's try another one. Very similar case. Again, the hand tips you off that these positions are different, even though they look very similar. They're still pretty rotated. This isn't a terrible lateral. It's not perfect or ideal, but certainly gives you an idea of what's going on. Just a simple reposition, and we can further see how much that corrects, and that makes a pretty drastic difference. I'm always amazed at how much the image quality can improve what the fracture looks like, getting good orthogonal views and kind of getting a better understanding. So this kid just needed a cast and really nothing else, whereas when I'm looking at these, I'm thinking we're going to be setting up for a little bit of a reduction or at least a well-molded cast with some pain medication. All right, we're going to move on to the pediatric elbow. I would say the pediatric elbow is probably one of our more intimidating areas to evaluate. A lot of that's because of all the ossification, the growth centers in these young kids, and it's just something that's very challenging. So some tips to that, again, that ABCS approach, we can see all of our bones pretty clearly. We have two views of the elbow. That's our standard set for a standard elbow. We can see the joint spaces are well defined. And then, generally speaking, like I said, there's two views, an AP and a lateral. The first thing I'd encourage you to look at on your lateral is always, is there an hourglass sign? So you can kind of see how an hourglass is formed here at the distal humerus. This is a really important finding because it helps you confirm you have a good lateral view and not a real oblique view. And we'll explain a little bit more as to why that matters here in a minute. So that's one of the things I would check early on. The other things, if you would look at these three things we're about to go over on every single elbow film that you look at, I think it's going to keep you from missing the majority of dangerous things. It may, I would not say it's obsolete and going to catch everything, but it's going to keep you from missing the bad stuff. So I'd encourage you on every single view to take this kind of methodical approach and look at these three things. Also be aware of those ossification centers. Utilize your contralateral views when you need to, and we'll cover a little bit of that in a minute as well. So number one, is there a joint effusion? So I guess to first ask that question and answer it looking at this film, you need to understand what a joint effusion is, or what we're looking for as a sign of a joint effusion on an x-ray. So a joint effusion is projected on the x-ray when these little fat pads that sit up next to the distal humerus, there is the capsule's underneath, and it's kind of like a deflated balloon is one way to think of it. When a fracture occurs, that fills up with blood and it displaces these fat pads. So the anterior fat pad kind of comes up like this little cell, and that projects on the x-ray what we call the anterior cell sign. The posterior fat pad, which is not usually visible at all on an x-ray, also becomes displaced, and you can see that it becomes visible on the x-ray. So going back to our film here, I would say that it does not look like there's an elbow joint effusion. You can see that little anterior fat pad, but it's not a cell sign, and I think that'll make a little more sense later as we look at some more of these. The second thing to look at is that anterior humeral line. So a line that comes straight down the anterior humerus should intersect that middle to anterior middle third of the capitellum. And then the third line is that radial capitellar line. So you want to make sure that the radial head is always pointing to the center of the capitellum on all of your views. If these three things are okay, then you can rest assured there's probably nothing terrible that you're missing. If you're still concerned this patient may have a fracture, the safest thing is always the safe answer is to splint them, immobilize them, and refer them out to ortho. The two views we mentioned are, like I said, the standard view for x-rays of the elbow. However, there are some instances where it's important to get some other views. These oblique images are utilized to kind of give us a better visualization, particularly the AP on this image, you really don't see a fracture. On the oblique or the internal oblique, it kind of highlights that lateral condyle fracture. And these things are sneaky. Sometimes you don't see much, particularly because so much of this elbow is unossified. It can be very sneaky. So when you suspect one of these, certainly don't hesitate to get that internal oblique. Same thing on the other side, our medial side, where these medial epicondyle fractures. Again, you look at the AP here, this looks like a pretty normal position for this medial epicondyle. But when we get that oblique image, it really highlights that displacement of that fracture, kind of gives you a better understanding of what's going on. You can see that soft tissue for that S in that ABCS series. That soft tissue really clues you into that as well. So we're going to move to a case study. This is an 8-year-old female, fell playing soccer 2 days ago. Mom presents to the urgent care with the patient stating that she's continued to complain of pain and she's guarded to using the arm. So you do a quick exam and you note that she does seem to have a mild palpable effusion of the elbow. She's focally tender over the distal humerus. She has limited range of motion and otherwise is neurovascularly intact. You get your x-ray report after you get your two views, and the x-ray report says no obvious fractures, but an elbow joint effusion is noted with a visible posterior fat pad elevation. So again, now that we know what that means, it kind of helps us to have a good understanding of what exactly that's showing us on the x-ray. And you can see this very clearly on this particular x-ray when you look right here at this anterior cell sign and this posterior fat pad sign. The rest of this elbow overall looks pretty good, I think, and we'll kind of look at that a little closer. But like we talked about, that's exactly what you're seeing, that anterior cell sign, that posterior fat pad. So what is the significance of that elbow joint effusion? What that tells us is that there is a fracture somewhere. In 1999, Skaggs showed us this with his study that showed that 3 out of 4 of these patients that present without a visible fracture line on an elbow film with a positive joint effusion in the presence of trauma did turn out to have a fracture 3 weeks later. By and large, most of these are occult supracondylar fractures. Occult fractures are very common in pediatrics. The word occult just simply means hidden, and that's exactly what these are. They're just hidden fractures you may not appreciate readily on initial images, and a few weeks down the road you see a little bit of healing to kind of indicate that those fractures were indeed there. So by and large, the supracondylar is the most common one of these. Our supracondylar fracture is the most common elbow injury we see in pediatric patients. There's a type 1, 2, and 3. We kind of break those down further. Type 1s usually will have either no visible fracture line, like the occult one we just discussed and looked at, or maybe a little tiny fracture here in the front that doesn't really extend any further than that. The anterior humeral line on this is a slightly rotated view, but the anterior humeral line is still in a reasonable position. The arrow here is kindly pointing out our posterior fat pad or our effusion sign. These type 1s, whether they're occult or you can see that visible line, they're treated with a cast, usually 3 to 4 weeks, and they tend to do well. Our type 2, there is usually a little bit of disruption of the anterior and posterior cortices with the posterior hinge remaining intact. You can again see that elbow joint effusion. However, when you draw that anterior humeral line on this one, you can see that that line does not intersect the capitellum, so that fracture is extended, and this is one that's going to need a little bit of help, whether that's a little bit of a reduction and see if we can maintain this with a cast, or whether or not this needs to go to the OR and have some pins put in it. And then on our type 3s, it's very clear that this is a problem. This will always need surgery. Not even worth drawing that anterior humeral line because you can tell it's not going to line up. Moving on, this is our next patient's a 10-year-old female. She shut her right elbow in a door leaving school 2 days ago, and she's continued to complain of pain. So mom brought her in for evaluation. On exam, you find no swelling or effusion. She has full range of motion of the elbow and forearm. She's not tender over the lateral aspect of the distal humerus. However, she is focally tender right here over about 3 centimeters distal to the olecranon tip. You get your radiology report from these 2 x-rays, and the radiologist has said there's a displaced avulsion fracture off the lateral humerus. I'm assuming with that read, they're talking about this right here, which would make sense. But going back to your exam, you notice that she didn't have any tenderness over there. So I think this is an important time to note. Your x-ray reads is an adjunct tool to your clinical exam, and you need to make sure that those findings correlate. They don't need to contradict your exam. By no means should we throw darts at our radiology colleagues. I think we have to remember that they're sitting in a dark room reading an x-ray and looking for any variations that may represent a fracture or an abnormality, but they don't have that patient in front of them. They don't have the luxury of having both the x-ray and the exam. So sometimes you will see this in pediatric reads because all of these ossification centers are there. When you get this read, if you need to prove to yourself or you have any concern that you may be missing something or your exam may not have caught the tenderness in that area or whatever the case may be, it's always appropriate to go ahead and get a contralateral view to kind of evaluate that and make sure it looks similar on her. You can certainly see that the left and the right are very similar, so this was just a bit of an overread. That happens, like I said, quite often with these ossification centers. There's such a variance of not only what this may look like by chronological age, but all these kids, every 7-year-old doesn't develop at the same rate. And every time you have one of these x-rays, there may be a degree of variability in there. So I do not think it's worth your time unless you are somebody that's going to be reading a lot of musculoskeletal imaging or somebody that does this in orthopedics day in and day out. I don't know that it's worth your time to memorize all of these mnemonics and kind of memorize when these ossifications appear, when they close. But I do think it's important that you recognize they're there and that you correlate those findings with your exam and with your x-ray findings. And if you ever have any questions about it, go back and look this up, look it up online, look up what those ossifications are, when they appear, when they fuse, all of those things will kind of help you come up with an accurate diagnosis. So we're going to talk about the adequate. So that's that first A in that ABCS series is adequate imaging. When we look at this x-ray, one of the things I had asked to always look at is the hourglass sign here at the distal humerus. And for this one in particular, you do not see that. Why that's so important, because a good lateral makes all the difference in the world in being able to interpret those other 3 things we mentioned. So if we're looking at this, I would first and foremost tell you I'm concerned about the image itself because we don't see that hourglass sign. Is there an effusion or not? It does not appear to be, but again, a lot of concern about the x-ray itself. So question mark on the effusion. How about that anterior humeral line? We draw that anterior humeral line and it does not look like it intersects that capitellum. Now keep in mind, this is a very young child. There's just a little nuclei there at that capitellum. So there's a bigger piece of cartilage that probably does intersect this to some degree, even on this poor lateral view. And then our next line, our radiocapitellar line, it does not line up as well. So certainly some concerns there, but what happens when we repeat this elbow? Ooh, now it's a little bit better. We can see there is an elbow joint effusion. You can see that posterior fat pad sign. You can see that anterior cell sign. Our anterior humeral line comes down and it does intersect that capitellum, although it does appear to be a little bit on the posterior aspect of it. Again, this is a really young kid who is a little flexed past 90 degrees. So those certainly have some impact in this. But I would accept this and think that there's maybe a little bit of angulation there, but not terrible. And then the radiocapitellar alignment looks great. So that kid is going to get treated for a supracondylar fracture as well. Our next one's a 12-year-old female referred in to the fracture clinic from an urgent care for an elbow dislocation, brought in these x-rays. Again, a lot of concern. I can see the 3 bones here. There's a lot of, they're superimposed. It's very difficult to interpret. There's no hourglass visible at the distal humerus. So a lot going on here that leaves me concerned about the image quality or the adequacy of the image itself. Same with our AP. It's not necessarily a great AP. You can see it's a little bit rotated, but more so I'm concerned on this lateral view. So what happens when we repeat it? We'll go ahead and repeat this with different positioning, and now we can see there's no elbow joint effusion. The anterior humeral line looks good. The radiocapitellar line looks good. So this patient had an elbow contusion and was just a little bit concerned by the urgent care that referred them in, and relieved when they got here and got sent home in a sling with a couple days rest, and should be back in no time to doing what they want to do. So repetition's the key to adult learning, so I'm told by some of my practice partners. We're going to do one more here. This is another elbow. Let's look for that effusion. Do we see an effusion there? I would say yes, there's an anterior cell sign visible. There's also a little subtle posterior fat pad sign, although it's a little bit inconspicuous there. Now let's look at that anterior humeral line. That looks pretty good. What about the radiocapitellar? Not so good there. That doesn't line up, and this is a problem. This is a dislocated radial head. This can happen for several reasons, but one of the most common is what's called a Montasia fracture, where there's a fracture in this ulna shaft, and that fracture has kicked up this radial head. This is an urgent referral, needs to be referred in, sooner than later, and probably warrants a call to your orthopedist to let them know they're coming in, or whoever your orthopedic referral source is. Okay, we're going to move on to the hand. Moving on to the hand, systematic approach again. Like all the other images we review, the ABCS approach still applies, kind of looking to make sure that you just have adequate views. The hand is at 3 views, so you typically want to have the 3 views. I like to start down here at the proximal end and look at the radius and the ulna first, and then work my way up through the carpals, looking at the carpal spacing, the carpal row, making sure that all of our joints are congruent. So you want to look at your carpal metacarpal joint, your metacarpal phalangeal joint, then your PIP and DIP joints. You want to kind of one by one trace these bones going up, looking through the cortices of these for little subtle irregularities. That becomes really, really important in our young kids that have unossified or skeletally immature bones. A good AP has the hand flat. You can visualize all of the joint space as well. On this hand, you can see these lines just past the epiphysis, which is this part here. You can see the physis, or the growth centers of these bones. These growth plates are important to evaluate. It's a common place. Really anywhere in our body that has a growth plate, that's an anatomic weak point. And for young children, oftentimes they will end up with a fracture through that growth plate, as opposed to something else we'd get in a more skeletally mature patient. So again, a good AP, a good oblique, and a good lateral. The great thing with the hand is, oftentimes we'll have finger injuries, and I always get the question of, well, do you get hand or finger images? And I often will elect to get a hand image, especially on our younger kids, because what that does is it gives you the other normal to kind of compare to. So sometimes when these are little subtle injuries or subtle changes in a fracture pattern or in a digit, you can compare it to the digit beside it and say, well, that one looks very similar. I think that's very helpful. When I order those, I'll generally ask for a hand and focus on X finger, or whichever finger it is that I'm trying to look at a little closer. First case is a 12-year-old male, injured the right ring finger playing football, presents to your urgent care with complaints of pain, swelling, limited range of motion. You can see that ecchymosis and that swelling kind of right through here, as well as over here dorsally on the PIP joint. So what next? What are you going to order? You're going to go ahead and order your x-rays. Again, hand versus finger. This is one I would really like to have a hand focused on that finger. We'll go ahead and get that. And here we go. This is our AP. That all looks pretty good. We're looking at that ring finger again. So when you know that that's the only finger, that's the only part of the extremity that's injured, you really can go in and focus more on that particular digit. But again, it helps to have comparisons. So looking at this, I can see a little soft tissue swelling, but overall looks pretty normal on our AP view. Then we scoot on over to our oblique, and we can see that soft tissue swelling pretty well now. Again, I don't see anything that's grossly abnormal there. The condyle, you could make the argument, looks a little bit off, but not terrible. So then we go, and this was the initial lateral this patient came in. This is not very helpful. When we look at this, I can't really evaluate that. The joint spaces aren't well visualized, particularly on the one finger we are needing to look at closely. You just don't have good visualization of that area that's injured. So this is when I would say let's repeat, and lo and behold, you can see very clearly that this patient now has a condylar neck fracture. If you had concerns of is this normal or not, well, you can look down to its friend beside it and kind of get that that comparison view of the other digit as well. And you can see that this one has a nice volar tilt, whereas this one has a dorsal tilt with a fracture line through it there. Condylar neck fractures are pretty common in kids. These are usually unstable injuries. The deforming forces will usually displace this fracture when it occurs, and so oftentimes these need to get fixed. So when you see these little subtle fractures, they may look pretty inconspicuous, but they can be bad actors, so certainly get them immobilized and get them into CS. They often will need surgery. Our next study is our next case study is a 14-year-old female. injured her left middle finger when it was struck by a basketball. She continued to play, but the next morning was more sore, swollen, and with limited range of motion, so they came in to get it seen. What next? Again, I would advocate to order x-rays of the hand and focus on the ring finger. So we get those views, a pretty normal AP again, nothing too alarming there. The oblique looks normal as well. And we get to our lateral, it looks pretty normal. Depending on what system or how your system works, it really helps to be able to adjust these images, and sometimes zooming in can give you a little more information. When I look at this, I can tell there's a little something right here, but it's not until we really zoom in that we can see a little more about what's going on. So on these lateral views is the best view for you to kind of evaluate for these avulsion injuries, particularly around the joints. This is what we call a volar plate injury, which is the quote-unquote jammed finger. When this is associated with a finger dislocation, it's a little more serious and can have a little bit of a poor sequela if it's not treated correctly. But when it's just the jammed finger that did not have an associated dislocation, usually these do quite well. We'll buddy tape them for a few weeks and then get them moving and let them get back to activities once they're pain-free with full motion. But certainly not something you want to miss. We're not too worried by the fracture itself. The fracture really just helps us confirm the mechanism of injury and what exactly happened. Physeal fractures, again, we've talked a little bit about those growth plates or mentioned them as we're going through here. Just always pay attention to the growth plates when you have open physes. This is oftentimes where you're going to find your fractures. The Salter-Harris classification is what we use to classify these. Again, I don't know that it's all that important for you to memorize that, but certainly to be aware that that mnemonic is there and that you can Google these or look these up if you need to, and get a description if you're needing it for charting or for referring this over to somebody who will kind of give you a little bit better understanding. But it's quite a simple classification system. It's Salter is the same level as for a type 1. The type 2 is the A, so it's above or in the metaphysis of the bone or involving the metaphysis. Below or lower than is underneath the physis where the epiphysis is, and then through kind of encompasses both the metaphysis and the epiphysis through the physis. And then the type 5, which is a rare finding, is really more of a crush injury. These classifications really help us to identify which ones of these are more likely to have a problem in the future with growth or with physeal arrest, and so we really use those to kind of help us classify that. These physeal injuries in kids can be quite subtle or very obvious. This patient here has 2. There's Salter-Harris 2 you can see here. Goes through the physis, involves the metaphysis, and then there's another. This is probably, even though it doesn't look like it crosses into the physis, most likely this does. This probably is an equivalent to a Salter-Harris 2 as well, although it may just be a metaphyseal fracture there. So getting adequate views, just like in the elbow, very important. This is not an AP view. These fingers need to be straight. This digit's kind of clawed, and I think that they wanted to highlight the image itself by spreading out the other digits, but what they ended up doing was just kind of taking away your ability to compare those digits to the abnormal or the injured digit. So straighten that hand out, get it really flat on the plate. That's really important to take the time. And sometimes it's just more about patience, and other times you may need to give the patient a little bit of pain medication first, but getting a good view is really, really important. It helps you make decisions. It helps you not make mistakes. And at the end of the day, doing that once as opposed to twice is beneficial for not only the provider seeing the patient, but also the family and the patient themselves. Again, adequate view. So this, you can see this digit, this AP view was taken with this finger flexed at the PIP joint, and boy, it really doesn't give you a great idea what this fracture alignment is. When you straighten that finger back out, you see that this, although there's a pretty nasty looking oblique fracture, the alignment of the finger itself is pretty good. So without any rotational deformity, this may be something you can treat non-operatively. You wouldn't really have thought that by looking at this first x-ray. So x-ray views matter, they're important. Make sure we're taking the time to get good ones. Now we're going to move on to the ankle. The ankle is another area that's extremely challenging to evaluate, both really with adults and with children. There is a lot of variability in the way that people want to evaluate the ankle. And there are numerous different measurements or angles that people want to use to try and quantify different injuries. I think some of those are applicable for pediatric patients. They're certainly more applicable for our adult and adolescent patients. But in pediatrics, sometimes there's just not enough of that developed yet for you to use those same measurements. But nonetheless, I think it's still important to kind of evaluate them. And obviously, in our older adolescent patients, we want to make sure we know what we're looking at and really more about what it represents. So our ABCs, again, this is a 3-view. You want an ankle with a 3-view image, plus or minus a stress view, which we'll cover a little bit here in a minute. And then we prefer these to be weight-bearing when at all possible. We also prefer to have that ankle at neutral or 90 degrees. Some basic anatomy, just knowing, when you're looking at these films, our tibia, our fibula, our tibial plafond is right here. Our talar dome is the dome right here. Then we have our syndesmosis that kind of holds the tibia and the fibula together. Our ATFL ligaments, or our lateral ankle ligaments, and our deltoid complex over here on the medial side. The medial malleolus is this bump here, and the lateral malleolus here. This makes that nice mortise joint that our talus sits under. So when we're looking at the AP view, I would start looking first at and you can go in any order, but again, I think it's important that you approach these step by step in your own way with a methodical approach. Some of the things that are important to look at, again, this is not by all means an inclusive list, but certainly some things that I feel like are valuable and important to look at. So the medial mal, or the clear spaces. So first, just evaluating the clear spaces across this talus. They should be pretty symmetrical, so you shouldn't be really wide on the medial side comparatively to the lateral side or even the superior clear space here. Particularly, you want to pay attention to that medial aspect, or that medial clear space. This is where that deltoid complex is, and if there's widening through here, that usually represents that there is a deltoid tear, and you need to be concerned about ankle instability. 4 millimeters is kind of the threshold. We generally say that if it's greater than 4 millimeters, then there is a rupture of that deltoid ligament. When you combine that, particularly with the increased tib-fib clear space or decreased tib-fib overlap, there's certainly a suggestion with that with syndesmosis injuries. The next things are tibiofibular clear space. So that's the space right up here between when we trace up the peroneal groove here, you'll see that we can get 1 centimeter above is where you want to take this measurement, and you go to the medial edge of the distal fibula. That measurement should be less than 5 to 6, depending on what literature you look at. Again, there's so much subjectivity in here. I think that some of this is really more kind of general guidelines to go by, and really your clinical exam and your experience is going to guide you as to what you need to do for these ankle injuries when they come in. But that's what you're looking at for that tibiofibular clear space. If it's greater than that, then you need to be concerned that there may be a syndesmotic injury. Tib-fib overlap, again, also a controversial measurement as far as the utility of this, but that's kind of the overlap between the two. Usually the normal is going to be greater than 6 millimeters on an AP. And then our talar tilt. Rather than looking at this from a standpoint of a measurement, I would tell you, I think it's important to look in the line of the plafond and the talar dome really should be parallel. They should run parallel there. There shouldn't be a perpendicular point where they're kind of intersecting, and if there is, then you need to be worried about some talar shift and, again, instability of that ankle potentially. Moving on to our mortise view. So the medial clear space, again, we want to evaluate there first. This is should be less than 4. The tib-fib clear space, again, this is a normal of somewhere between, it should be less than 5 to 6. And then, again, you measure up that peroneal groove right up here, about 1 centimeter. That tib-fib clear space here, number 3. And then 4, again, looking at that talar dome and the talar tilt there, these should be parallel coming across. The talar dome, this is also a really good view for you to evaluate for osteochondral injuries. These are usually going to be on the side, either right here at the dome or over here at the dome laterally. Great view to evaluate that. We're going to move on to the lateral view. So on the lateral view, some of the images, the important images to look at or things to evaluate here. You're looking for a fibula fracture. This is often where you're going to find those oblique fibular fractures, those Weber classifications. You'll oftentimes not see them so well on the AP view because they'll be hidden, or on the mortise view they may be hidden. Usually you'll find them on this lateral view. So that's what you're looking at here, is that fibula kind of superimposed in the background of that tibia there. The posterior malleolus, this is the best view to evaluate that posterior malleolus right here. And then again, to just kind of make sure that your talus is centered under the plafond of that tibia there. It's also a great view to evaluate the 5th metatarsal. When you have a fracture here, sometimes you'll see a little lucency running through there that you may not see on your AP or mortise view as well. The calcaneus is well visualized, and the talus and talus neck are also well visualized here. Stress views, when do we get them? Why do we get them? Well, again, that's a very controversial thing. I think this varies provider to provider, and the first thing I'd ask you is, depending on where you work, should the stress view be something that you are concerned about getting? I think, just like all these mentioned here, reasons we think we need to get stress views, it really boils down to if we think there's an unstable ankle, we want to get a stress view to prove it if we can't already tell that on the 3 normal views that are there. Medial-sided symptoms or suspected deltoid ruptures, isolated Weber B or Weber C fractures, and then just your general clinical exam findings. If you have concerns, that's when we would consider this stress view to kind of prove that for us. The question for me would really be, or I guess the question I would have for you would be, is it really going to change your acute plan for that patient? So if this patient's in your urgent care, in your emergency room, you know that you're going to be putting them in a splint and sending them over to sports or sending them out to your ortho referral. Does this stress view really change that for you? And the reason I'd say that is because quite often we may get them in our office here, and everybody's pretty particular about these, and sometimes we want to stress these ourselves, or sometimes we're going to want to do these views ourselves. So it may not be worth you taking the time or putting the patient through a stress view. It may not add much to your decision making. I do think this varies based off of where you practice, and so I'd encourage you to talk to whoever your referral source is, whoever you send these patients to, and ask them what they want. Kind of get their opinion what they want. It may save you some time and some effort in the long run, when it really may not make a big difference at all on what you're going to do for this patient in the acute setting. Some other common fracture signs we may see. So this is the Misty Mountain sign. You can kind of see this faint line running through here. This is an indication of a posterior malleolus fracture. The double contour sign, another sign of a posterior malleolus fracture. Some common accessory ossicles to know. There are many of these, but these are probably the 3 most common and ones that often get misinterpreted as a fracture and avulsion injury. These can have an avulsion injury associated with them, but essentially these are unossified accessory ossicles that are extremely common. This os subfibulaire, the os subtibial, and the os trigonium. So when you see these findings, just know that this probably does not represent a fracture when this is really well rounded, corrugated. Correlate your clinical exam findings with the x-ray read. Sometimes these will get called as a fracture, or you may look at the x-ray and believe this is a fracture, but if that patient's not tender there, well, that's not a fracture. A couple scenarios we'll kind of look at with you utilizing those measurements that we talked about earlier. This is a patient that came in with this Weber C fracture. You can clearly see here there's widening of that medial clear space. There's also widening of the tib-fib clear space. This is an indication that you have an unstable ankle. That deltoid's been disrupted, your syndesmosis has been disrupted. And this is how we fix that. So we put a plate on here to straighten out and get that fibula back in a good position. And we put this tightrope in here to kind of have this syndesmosis reduced and kind of back to a stable ankle. So the utility of that stress view, something will give you a good example of that. If you look at this AP of this patient, again, Weber C pattern, you look at this 1 centimeter up that Pernod groove, and you measure across, you have a 6.5, so it's a little bit wide. You kind of suspect, because they have this lateral or this medial ankle swelling, they're tender over that medial side, so your clinical picture leaves you suspicious for an unstable ankle, so we did go ahead and do manual stress on this patient. You can see the hand down here that's manually stressing them as opposed to a gravity stress view, which is also something that can be utilized. And you can see that this opens up, we're 6.4 millimeters, so again, this is another unstable ankle that needs to be fixed. Now we're going to look at this 10-year-old female who was injured sliding into second base. AP view looks pretty good. Those measurements all look pretty good. This is a little bit younger child, so again, the measurements are good guides, but I don't know that they're always applicable to some of our younger children. When we look at this oblique or this mortise view, you're going to see some widening of the physis or the growth plate over here medially, and it's a little hard to tell exactly what's going on, but it just doesn't look right. So something's going on in that growth plate or in that physis. You can also see there's a little bit of step off right through here, again kind of indicating that there's some disruption of that growth plate or that physis. So then we look at that lateral view. In this case, it's not necessarily the posterior mal, but this is that view we said is good to look in this location. And for this particular patient who's 10, she gave, or the fracture occurred through her physis. It was that anatomic weak point, and she had a Salter-Harris 2 fracture. So this little triangle fragment we see on these metaphyseal Salter-Harris fractures is called the Thurston-Holland fragment. That's exactly what you're seeing right here. She's a little bit kicked up. So again, the same level. So if this just involved the physis itself and did not involve the metaphysis, that would be the type 1. In this particular case, it's above the physis into the metaphysis. So this is a Salter-Harris 2. And like we mentioned, that's that Thurston-Holland fragment that's there. Next is a 14-year-old male with a supination external rotation injury during football. The AP looks pretty good. The mortise looks pretty good. It's a little bit, not quite as good of a mortise view as I would love to have, but again, not terrible, and looks overall pretty normal. And then our lateral view looks pretty good. There's a little bit of an irregularity right here. I don't think that has to do with our particular injury, but I think that may just be some artifact. And then when we look a little closer at our AP, now you can see there's something going on right here. So always evaluate, trace those cortices through those bones, kind of look for any kind of a step off, any kind of a gap or an irregularity. Sometimes they can be quite subtle, particularly in these young kids with open growth plates. This is not such a young kid, but they are transitioning. This is what we call a transitional fracture. This is a Tillot fracture, and so you can see the majority of that physis is closed. The part that remains open at this 14-year-old's age is this lateral margin over here, and so that's where this fracture occurred. Again, the weakest link in the chain is what gave. So this kid has a Tillot fracture. This is a Salter-Harris 3 because if our physis is here, the metaphysis is up here above it, the epiphysis is below it, and we can see that this really only involves the epiphyseal piece of this. Next, we're going to move on to the foot. This is our final one, so we're making it. We're getting through there. Everybody grab your coffee, take another long drink, and we'll kind of plug through this together. So the foot, we get a 3 view on the foot. The AP, the lateral, and the oblique. Again, we prefer weight bearing when at all possible. I think that if you can have the patient make an effort to weight bear, even if they can't fully weight bear, it certainly helps us get a little bit more adequate views. Knowing your anatomy, so kind of just being able to describe the hind foot, the midfoot, and the forefoot. You can see that on the AP. You can see that on the lateral as well. So looking at this AP view, again, I would start down here at our distal end of the tibia and fibula. You can kind of see those. You can see a little bit of the distal end of our calcaneus and our talus. And then you're going through our tarsal bones. You want to make sure that your mid-talar line passes through the center of the talus to the medial base of the first metatarsal. You want to make sure that the medial calcaneal line passes through the fourth metatarsal. You want to go joint by joint and kind of look through here. The one you're going to look at really closely, or I'd encourage you to look at really closely, is this Liz-Frank joint, particularly in our older adolescents, as Liz-Frank injuries are very rare in young kids. They can occur, but it's not a very common injury to occur. But you want to make sure that this is a congruent joint. You want to make sure that the medial margins of the first through the fourth metatarsals align with the retrospective cuneiform or cuboid. Paying special attention to this area here. If there's widening, go ahead and get that contralateral view and you can compare the two. And then just globally evaluating the midfoot and the forefoot, looking through as you're moving on from the tarsal metatarsal joint. You're going to squeeze on up to the metatarsal phalangeal joints. And then the phalangeal joints as well. You want to make sure you're tracing these cortices one by one and looking for really subtle injuries because, again, especially in our younger kids, these can be pretty inconspicuous. On our oblique view, this is one of the better views to be able to see the bases of these metatarsals. It gives you a really good view of the base of the fifth metatarsal. Metatarsal neck fractures are often seen on these. And then our phalangeal fractures, this certainly helps there as well. Again, I would take the approach of correlating your clinical exam findings, find out where you need to be really suspicious and kind of hone in on those areas, focused and kind of look at those things we've already talked about. On the lateral view, this is the best view for your hind foot, gives you a great view of the calcaneus, of the talus. You can kind of look for calcaneal compression fractures here, talar neck fractures. It really gives you a good view of the soft tissues, which is certainly helpful sometimes as well. And then the Liz-Frank joint, again, you're going to look for some dorsal displacement here, particularly if these kids come in with a big swollen foot, a hyperplantar flexed injury. And then you're going to evaluate for that and make sure that there is not a Liz-Frank injury there. Case study for this one, we're going to look at an 11-year-old male who landed awkwardly on his foot while jumping on a trampoline 2 days ago. He presents to an urgent care with pain in the foot, swelling, and difficulty walking. He has dorsal soft tissue swelling, just kind of globally, especially in these young kids. You're going to see this kind of global swelling over the dorsal aspect of the foot. Pretty tender over the second through the fourth. Again, being able to rely and trust your clinical exam is important, but it's not always easy because it's hard sometimes to trust the 11-year-old clinical exam, and you may get a situation where everything you touch is tender or sore. Not always, but a lot of times that's the case. And so kind of correlating where you find the most or where they're most sensitive at with your x-ray findings. So we go ahead and get our 3 views for this particular kid. AP looks okay. I'm sorry, this is actually our oblique here. Looks okay. Our AP looks good. Lateral looks pretty good. Where do we have that swelling at? So again, we had dorsal soft tissue swelling globally over the midfoot, and they were focally tender at the distal end of the second through the fourth metatarsals. So that's kind of this area right through here. And when I look at this, much like the hand, I like to be able to compare the other digits. So when you look at the fifth and you compare that to the fourth, those look pretty similar, but when you go over and you look at the necks of the second and the third, they do look a little bit different there, and that's that area where he's sore. So when we blow that up and look a little bit closer, we can see there's a little bit of a cortical buckle here. So this patient does have fractures at the second and the third metatarsals, perhaps even the fourth metatarsal. So this kid would get a boot immobilization for about 5 weeks, somewhere between the 4 and 5 week mark, and they should heal and do well. Base of the fifth metatarsal injuries. These are really important and often confusing as well because of this apophysis, which is this right here. So our apophysis here appears at 8 and unites somewhere around 12 for females and 15 for males. It leaves a wide range of variants of what this thing may appear to be. And oftentimes you're going to be dealing with something where you have an insidious onset, meaning this patient either has repetitive overuse or kind of a slow onset of symptoms, or they come in and tell you that this area has been off and on hurting with activities over the last 2 weeks or the last 4 to 6 weeks, but nonetheless just a slow insidious onset. They can't really give you one specific event that caused that injury. So you really want to, when you have an injury to this area, you really want to listen closely to that clinical exam to that clinical history and find out when the symptoms started, how did they start, and kind of be able to associate those findings. What you're going to be looking for is, with an acute trauma, is usually an inversion injury. So usually that peroneus brevis that attaches here will kind of pull that off and create a traction injury over that apophysis. Sometimes the x-ray for a young skeletally immature patient with this apophysis can look very similar to that of a fracture and a avulsion injury in that area, and we'll cover that here in just a minute. The easiest way for me to think of it, or what I would really suggest everybody thinks of these, is that a transverse line going across that metatarsal base or tubercle is a fracture, whereas a vertical line usually is going to just represent your apophysis. So transverse is bad, vertical is usually an anatomic variant or a developmental variant. We're going to look at some examples of this. So our first patient, patient number 1 here, this is that developing apophysis. Again, you can very easily see how somebody would interpret this as a fracture, particularly if the radiologist is sitting back there looking at this. And all the chart says is they have pain over their fifth metatarsal, but they don't really have any other history to go with that. They don't have a clinical exam finding to go with that. So this particular patient was a insidious onset for a few weeks, has been hurting intermittently, seems to get better with rest, and comes back with activities, particularly when they play soccer, which they play 3 or 4 days a week. So this is probably going to be Island's apophysitis with that clinical picture, which is just inflammation. It's kind of the Osgood-Schlatter's of the foot. The second scenario looks pretty similar. This is a skeletally immature patient that has that same apophysis you can see here, but that apophysis is a little bit wide, and again, that may be a developmental variant, but it also may be an avulsion fracture through that apophysis. So how are you going to know the difference? Again, go back to that clinical history and kind of find out when these symptoms started. When you find out that this is a pitcher who threw a pitch, felt their foot invert and felt a pop, well, now you know that this was an avulsion injury with an acute fracture through that apophysis. And then the tuberosity of avulsion fracture, as we kind of look across, this is a transverse line, not a vertical line, but that transverse line runs across here into that joint surface. And that's our tuberosity fracture, same mechanism. This is usually an inversion mechanism. And then our Jones fracture, this is a little bit further down or a little more distal down the shaft of that fifth metatarsal. This can be a bad actor. It's a really important one to catch and not overlook or miss. These tend to have a problem healing because of the blood supply to this area. So these are 4 very different injuries that can have very similar x-ray appearance. And so I would really encourage you to focus on your clinical history and kind of correlate that with what your x-ray findings are when you evaluate that fifth metatarsal. Some other common injuries in our really young kids, one of the more common areas we see fractured is particularly with these kids under 5, is this base of the metatarsal. And there's not always a line going across here. A lot of times it's kind of that comminuted fracture where it's almost like taking a Coke can that's empty and squishing it a little bit and it just wrinkles up in that area. You can see that little comminution there on the lateral margin of that first metatarsal. These good news is that they tend to heal really well. This is a brief period of mobilization for comfort more than anything else, and this patient will heal and do fine. calcaneal-cuboid avulsion injuries. So that oblique image oftentimes is going to be the best view for you to find these on. You can see here there's a cuboid avulsion, calcaneal avulsion. Really pay attention to this area as well, particularly when these kids come in with an acute injury and kind of global mid or lateral midfoot pain. And then we can obviously see this, long oblique fifth metatarsal shaft fracture here. Physeal injuries, I feel like we have to at least cover one of those on this as well. And so one of the more common places we see this in the foot is at that great toe. This is that kid that jams their toe or stubs their toe outside throwing the football and kind of rolls over the top of their toe. And they end up coming in with a big swollen toe. And you get an AP view that looks pretty normal. I don't have the oblique on here, but these obliques usually look very normal as well. And the proof in the pudding for this one's going to be on the lateral view. So when you get that lateral view, you can look for that little Thurston-Holland fragment right there. You can look and see that there's widening through this distal phalanx, the physis of this distal phalanx. And so when you see this fracture, the next thing you need to question is really what the nail bed looks like. So just like in our hands where we get Seymour fractures, the foot can do the same, where this particular fracture may extend and push the nail plate out from the nail fold, making this really an open fracture. And so that's something that you're going to want to make sure you evaluate for, because that needs to be treated a little bit different and very likely is going to need to be washed out, irrigated, and debrided a little bit. So in summary, be sure to get adequate and appropriate views of the injured extremity. It's extremely important that you work with your team and make sure you're taking good views. It helps you not only as the clinician to come up with the proper diagnosis and the correct treatment, but it also is helpful for the patient, because their next stop, they may not have to repeat those images and further costing them money and radiation exposure and so on and such. Use a systematic step-by-step approach to review every x-ray. Just like anything else we do with our clinical exams, the more you do this, the more repetition you have, the better that's going to become, and the more second nature it is to you. And then paying close attention to those anatomic and developmental variants in the pediatric patient. These x-rays need to correlate with your clinical exam, not contradict it. And then just remember that pediatric fractures can be very difficult to identify. So when in question, despite a negative x-ray, don't hesitate to immobilize these patients and send them to ortho and let us kind of sort it out. That's always the safe answer. Again, I really appreciate you guys tuning in today, and I hope you got something out of this lecture. So now I'm going to switch gears a little bit. I'm going to introduce Manish John, who is our manager of our radiology department here. Manish is a radiology technologist, and him and his team are fantastic at getting these views. Quite often patients will come in with views that are a little challenging to interpret, and we really lean on Manish and his team a lot to get better views for us. So over time, they have developed a lot of tips and tricks, and I think they can pass on some of that wisdom, some of those pearls to you on how to get some better images, particularly in your pediatric patients that may or may not be so helpful. So again, appreciate your time today, and I hope all of this has been very beneficial for you. Thanks.
Hello everyone, welcome to Scottish Rite Frisco Radiology. My name is Manish John. I'm the radiology manager here, and we're so glad that you were able to join us today. So we're going to spend the next few minutes just talking about how to get optimal x-ray images that give you the best plan for treatment of your patients. So we'll discuss positioning methods for the forearm, elbow, hand, foot, and ankle. I'll share with you just a few tips and tricks that we've learned over the years to help get the images you're looking for. And lastly, we'll review some image criteria so you know what to expect when you see your x-rays. So let's take a look at our earlier case study of the gymnast with a fractured forearm. So we're going to order two views of the forearm, a PA and a lateral. So we'll discuss the next steps in positioning those two views. For the PA forearm, we'll ensure that the elbow is flexed 90 degrees. You have the humerus and the forearm all on the same plane. What this does is it avoids any kind of distortion of the anatomy. The hand should be flat on the detector. Include the metacarpals as well as the distal humerus, and center array should be at the mid-forearm. When positioning for a forearm, a lot of the patients come in and this is a natural position that they want to be in. But it's important that you place one hand on the wrist, one hand on the elbow. This allows you to have as much movement of the forearm as possible, and also allows you to support the fracture. And this gives the patient a little bit of comfort. So Supinate the wrist about 5 degrees, internally rotate the elbow, and that gives you the radius and ulna superimposed on top of each other. So when you go to make measurements and check alignment, you'll have a much easier time. Let's take a look side by side of 2 x-rays of the same patient, but different positioning. See how positioning can definitely alter your plan of treatment. So on the first image, the hand is oblique and not completely flat on the detector. Not a true PA position. So this could make your fracture way worse than it actually is. Let's look at the lateral. Like we discussed earlier, this arm is left in its natural pronated position. The radius and ulna is not superimposed on top of each other, so you're going to have a difficult time checking alignment. It's important to supinate the wrist 5 degrees with a slight internal oblique of the elbow. Another common x-ray that we see through the fracture clinic is the elbow x-ray. The elbow x-ray is one of the harder ones to position for because there's so much of the anatomy that we want to make sure is aligned perfectly. And a lot of times the patient is in extreme pain, so it's hard to position for this particular view. But let's walk through how to position for a AP and lateral elbow. Positioning for an AP elbow. When a patient comes in from an elbow injury, a lot of times they're guarded and will only give you so much movement. It's important to get that elbow fully extended, and there's a few ways to do that. One is to just explain to the patient the importance of extending the elbow as much as possible. Second is assisting the patient getting that elbow extended while fighting the resistance. And the third is just using distraction techniques like asking if there's any pain here or any pain here while extending the elbow. So once the elbow is fully extended, you want to supinate the wrist slightly, and that gets the ulna and the radius slightly separated. Going from an AP position to a lateral position, you want to flex the elbow 90 degrees. Ensure that the humerus and forearm are all in the same plane. Another great method for getting a true lateral of the elbow is what we call the stop sign lateral. So this is great for patients who aren't able to sit up straight or who have a difficult time holding still. So this is really good for some of our younger patients. So in positioning for the stop sign lateral, you want to ensure that the patient is supine. Flex the elbow 90 degrees, almost make a stop sign. One hand will be on the wrist and the other one will be on the proximal humerus. When you have a true AP and lateral image, you should be able to visualize the radial head, neck, and tuberosity slightly superimposed. The elbow joint open and humeral epicondyles not rotated. Olecranon fossa should also be in the center. On the lateral view, you should have superimposed humeral epicondyles, a good visualization of the hourglass. Radial head is partially superimposed over the coronoid process, and a good visualization of any elevated anterior or posterior fat pads. So now let's take a look at positioning for our hand and finger x-rays. We use special tools like the hand spatula and a radiolucent sponge to help with positioning our patients. When positioning for a PA hand view, it's really important to get the hands as flat on the detector as possible. A lot of times the patients come in and because of pain or stiffness, they tend to curl their fingers. So there's 2 ways to get the hand as straight as possible. One is to press on the hand as much as possible to get it completely flat, and then spread the fingers slightly. And the second way is to use our hand spatula and just press down on the hand. So going from a PA position, you want to rotate the hand about 45 degrees off of the detector. The digits still should be separated slightly, and you want to ensure the digits are straight and not curled. So this allows the joint spaces to open up. For a lateral hand x-ray, it's important to fan the fingers. The digits should run parallel to the detector, and using a radiolucent sponge will really get the hands in a true lateral position. So in the AP view, You want to see slightly separated digits, no soft tissue overlap, open metacarpal phalangeal and interphalangeal joints, and include the distal radius and ulna. On the oblique, there should be a separation of the second and third metacarpal shaft, minimal overlap of the fourth and fifth metacarpal shaft, and on the lateral, the hand is in a true lateral position with extended digits. So now let's take a look at positioning for an ankle view. 3 views of the ankle: AP, a mortise, and a lateral view. So positioning for ankle, ideally you want to do it weight bearing because you can see the joints in action, but we know that's not always possible. So we're going to do this supine. For AP view, you want to slightly dorsiflex the foot. The malleoli should run parallel to the detector, and you want to center your central ray at the mid malleoli. Positioning for a mortise view, you want to dorsiflex the foot, internally rotate about 15 to 20 degrees, and then center at the mid malleoli. Positioning up for a lateral ankle, turn the patient to their affected side, have them dorsiflex the foot, center at the medial malleoli. So let's take a look at the image criteria for the ankle. For the AP position, you should have a moderate overlapping of the tibiofibular articulation. The oblique or mortise view, ankle mortise should be in profile. The open space of the lateral and the medial malleolus articulation with the talus. On the lateral, the tibiotalar joint is well visualized and the fibula over the posterior half of the tibia. Let's take a look at positioning for the feet x-rays, AP, oblique, and a lateral view. In positioning for the feet, we're going to flex the patient's knees until the foot is flat on the detector. You want to center at the mid-foot, and angle of your x-ray tube should be about 10 degrees. And what this does is it opens up the joint spaces of the foot. So going from a AP to a oblique view, want to internally rotate the foot so the plantar surface is 30 degrees off of the detector, and your central ray should be at the mid-foot. For a lateral position, you want the patient to lay on their affected side and dorsiflex the foot, and you want the plantar surface to be run parallel to the detectors. And then center at the midfoot. Let's take a look at the image criteria for the feet. On the AP view, you should have equal amount of space between the adjacent midshafts of the 2nd through 4th metatarsal. Oblique, the 3rd through 5th metatarsal bases should be free of superimposition. The lateral, the metatarsals should be nearly imposed, and the fibula is overlapping the posterior portion of the tibia